We go on to our next speaker, Dr. Leila Mohan, who's the Chief Consultant Surgeon, Contrast Eye Hospital, Kozhikode, Kerala, our dear friend, and we look forward to hearing her talk on weakening procedures on the inferior oblique muscle. On to you, Dr. Leila.
Thank you so much, Dr. Chitra, for including me in this wonderful session. You can see my slides?
Yes.
Okay. So inferior oblique overaction or over elevation in adduction, as is termed by Sima's classification, presents with a V pattern and extorted fundus. Primary bilateral inferior oblique overaction is seen in long-standing horizontal strabismus. It's not uncommon in infantile strabismus, infantile essential lysotropia, where 60 to 70% of them can have present later with inferior oblique overaction, and 35% in accommodative esotropes, 30% in exotropes, and associated DVD as well may be there. And secondary inferior oblique overaction, the most common is secondary to superoblique palsy on the same side, or contralateral superior rectus paralysis also it can occur. It's not moving, I'm sorry. Okay. So this is a bilateral primary inferior oblique overaction. Over elevation in adduction is seen in both eyes with a V pattern and extorted fundus. Primary gaze, he had no horizontal deviation, but exo in elevation and eso in depression. So depending upon the grade of inferior oblique overaction and V pattern, we have to decide how much weakening should be there and whether we should touch at all. So grade of upshoot in adduction is important. This is there are various types of grading. This is a grading according to the reflex, which corresponds to the abducting eye. This is the abducting eye with the central reflex, and the adducting eye shows a reflex between the pupillary center and pupillary margin. Grade 2 is at the pupillary margin, grade 3 between pupillary margin and limbus, and at the limbus is grade 4. Unless there is a V pattern of more than 15 prism, a grade 1 inferior oblique overaction need not be tackled by surgical correction, and just horizontal recess resect may be enough. If there is bilateral asymmetric inferior oblique overaction, you would do asymmetric recession. But if you do a unilateral one, the other eye will start upshooting more. So in amblyopia and a manifest DVD, you may do a unilateral inferior oblique because the other eye may not manifestly dissociate. So in isolating inferior oblique, good exposure is important to prevent leaving behind any posterior muscle fibers. Surrounding orbital fat should not be disturbed. Fat adherence can occur, and you should be careful not to disturb the vortex vein also. Meticulous dissection is important to see the posterior fibers. And these are two methods to isolate. You can either pre-place the sutures or put the sutures after severing the muscle. Surgical procedures include recession, temporal myotomy, myectomy, anterior transposition, nasal myectomy, disinsertion, denervation, and denervation extirpation. But myectomy, recession, and anteriorization are the most commonly done ones. So coming to myotomy, Z myotomy can be done. In myotomy, you cut between the clamps, cauterize and leave the proximal end to be retracted into its sheath. And in marginal Z myotomy, you clamp the opposite edges in a Z fashion and then cut it and cauterize the edges. In myectomy, after clamping on either side, you cut resect about 6 to 8 millimeters of the segment of the distal muscle and leave it after cauterizing. The main advantage is simple, and it is fast and less risky because you are not taking the sutures on the sclera, and muscle can get attached to sclera anywhere from insertion. So it is very unpredictable. And recurrence after myotomy can be as high as 70% and myectomy 50%. So a more controlled weakening is inferior oblique recession, and inferior oblique relocation is also possible easier after inferior oblique recession in reoperations. So in grade 2 inferior oblique overaction, about 8 to 10 millimeter of recession, which is the standard one. This is Sparks point being measured about 2 millimeter away from the insertion of inferior rectus and 3 millimeter inferiorly. It gives about 8 to 10 millimeters of recession. things you can even measure from the resected muscle, I mean the disinserted muscle. And Fink's point is 6 millimeter below and posterior to the anterior insertion of lateral rectus and corresponds to about 4 millimeter below inferior rectus. And the more anterior is the fibers inserted, the greater is the weakening effect. And asymmetric recession can be done according to the severity of the overaction. And anterior transposition, as proposed by Elliott and Ankin, the neurofibroblastic bundle mechanically acts as a new origin. It's inserted to the posterior fibers, posterior margin of the middle of the inferior oblique, and a J deformity is created by anteriorizing according to this Elliott and Ankin. That is, the insertion is at the insertion of the inferior rectus, and you can see it is parallel to the fibers of the inferior rectus, which creates J deformity. And modification, this usually produces an anti-elevation effect, which is desirable in some of the cases like DVD when it is manifest, or hypertropia in superoblake palsy. So at the modification is to prevent anti-elevation where the bundles are bunched up instead of spreading it out, or the posterior fibers are sutured along the lateral border of the inferior oblique, and it is done, it prevents anti-elevation. So anterior nasal transposition of inferior oblique can be done in recurrences where you isolate the inferior oblique. After hooking the muscle, you suture it about 2 millimeter nasal to and inferior to the insertion of the inferior oblique, inferior rectus insertion. And it is done in a very large hypertrophy in primary position or absent superior oblique tendon. And in these cases, it is converted from an extorter and elevator to an intorter and depressor, but anti-elevation apparently is less than in the temporal transposition. Yeah, so this is an algorithm when there is +1 about 4 millimeter behind inferior to inferior rectus, +2, 3 and 2, that is 3 millimeter posterior and 2 millimeter lateral is the Parkes point, +3, 1 to 2 millimeter posterior to the insertion, and +4 at the insertion, as we see here. And indeed,
you have 1 minute remaining, ma'am.
Okay. So this is a superoblake paralysis, which produce, you can see the hypertropia increasing in opposite gaze and Belchowski positive. After superior oblique traction test, which showed negative, we did just an inferior oblique anteriorization, and she is completely corrected the head posture and no anti-elevation. But in this case, I'm sorry for that sound. Sorry. Sorry. She has some amount of anti-elevation after doing the inferior oblique transposition, but anteriorization. But she is happy because the head posture is gone and primary position, and in depression there is no hypertropia. So complications, residual inferior oblique overaction is the most common one due to missed posterior fibers, or even otherwise it can occur, as shown by various authors to be 46 to 67%. The recurrence may be there. Anti-elevation may be desirable in manifest DVD and superoblake palsy where there is hypertropia. Fat adherence due to disruption of the orbital fat leads to progressive hypertropia, limitation of elevation and positive force reduction test, and a lid retraction. Ciliary nerve damage can occasionally occur with the temporary pupillary dilatation and injury to lateral rectus or vortex vein, which are rare. To summarize, unless there is a definitive over elevation in adduction, you will not touch the inferior oblique. I'm sorry. Okay, that's done almost.
Yeah, wonderful talk, wonderful, and so packed with information. Dr. Veena, shall we take a question or shall we move to the next speaker?
We can go to the next speaker, madam.
Yeah, she really